why don't I throw it out to our surgeon here? Are you seeing any changes? Are more of these patients now being treated in the community now that we have approved drugs?
Yes, I think there is now an outflux where now that we have some approved agents, people feel comfortable that they actually have guidelines and level 1 data, whereas before they were basically doing best guess and not feeling very confident about what they did. And we're seeing a lot more patients coming to a center, perhaps getting recommendations from our multidisciplinary group, and then returning to the community and doing very well being managed by their local oncologists with these agents.
You mentioned the multidisciplinary group. What other physicians do you involve in decisions to help treat neuroendocrine tumor patients? They have all kinds of things that happen, endocrine symptoms, heart problems, bowel problems.
That's what makes it fun, is that we get to have a very large group of experts. So besides myself being a surgeon, we will certainly have medical oncologists. Interventional radiologists have historically played a very large role with embolizations, chemoembolizations, and now they're doing radioembolizations. Endocrinologists for the hormonal syndromes and some of the workups that are required, nuclear medicine physicians for not just the functional imaging like the Octria scans, but also they do, in other countries certainly, they do the, what James mentioned as PRRT, which is peptide receptor radiotherapy. Cardiologists, because patients who have metastatic disease to the liver from carcinoid will certainly be at risk for having carcinoid heart disease. And while that may not be clinically overt in a patient that we see murmurs or evidence of congestive heart failure, certainly before I do a major liver resection, I want to know if they have subclinical carcinoid heart disease. And so we will involve our cardiologists. So it's a very broad field, very inclusive.
And I might add one important member to that team, which is the pathologist.
Oh, yes.
I think that as we talked earlier, that histology can, we often see striking differences with outside pathology review and academic pathology review. I think that's...
And medical geneticists because of the genetic components.
Yeah.
Have you been seeing a shift as well more into the community now that we have approved drugs in terms of your referral patterns?
I have seen that. I think that some of the patients who've had a relationship with our academic center will often continue to stay in touch and may check in at times that new decisions need to be made, particularly because most of our community oncologists now know that there's growing available clinical trials, and I think that that's something that we try to make available to our community docs too.
What I'm hearing, though, is that there probably still is some value to have these patients come in early to at least have access to some of the various different specialists that really can be helpful in determining the treatment course.
Well, I think that's something that Pam brought up earlier, was the whole question of treatment sequencing. And in a great deal of this, we don't have a well-defined sequence. But having said that, there are certainly things that can be done that will ruin a sequence. And for example, as a surgeon, one thing that I frequently saw is that someone would be diagnosed with neuroendocrine tumor with liver metastases, and about the only thing that anybody in the community knew to do was to chemoembolize that. And so they would just order that right away. And the patient could have had stable disease for quite some time before that would have been required. Most every embolization series has a death rate associated with it. So if we just did that to everybody, we would probably lose some patients unnecessarily. And sometimes I look at the disease, because they come to me after the embolization for an opinion, and I say, well, that's resectable, but if it's embolized and all scarred in, it can be a very dangerous operation. So I think that we need to think ahead to the best of our ability, and we need to be thinking 3 to 5 steps ahead at this point with so many options.
At your cancer center, James, do you have a fixed sequence that you like to use, or do you sort of tailor it to the patient and like to see them up front?
Yeah, I think we definitely would try to tailor to the patient, and it's many different things. I mean, it's everything from the patient's, age, comorbidity, amount of disease that's present, and we heard both the primary side and the grade plays a big role in terms of how these tumors are going to behave. So we definitely try to tailor it. I think, as you said, there is some change in the referral pattern with the new agents that are approved. And that may be good because I think these patients do like to be closer to home when they're managed at all possible. But I also want to plug clinical trials because the way you make progress is to do clinical trials. Although we have a couple of agents available now, there's still a lot more left to be done. There's still a lot of unmet need. Most of these patients will survive their initial treatment and are quite well, and they're going to need more. And so that's where I think the field will have to head toward.
Great. Well, thank you very much.